Good afternoon, everyone. We're going to get started as people slowly join the call. A very warm welcome to everyone who's joining us today for our third annual Ocular Melanoma Patient and Caregiver Symposium. My name is Jasmine McGowan. I'm the Managing Director here at Save Your Skin Foundation and Ocumel Canada. So this year's focus is on translating the very latest global research, particularly from recent conferences like ESMO and SMR. And we want to turn this into practical insights from the Canadian OM community. So over the next 2 days, we're going to explore what these updates mean for patient care, support, and hope. And of course, how we're going to take this information and move forward in Ocumel Canada into 2026. So before we begin, I just want to have a really few quick notes to ensure a really smooth experience for everyone that's on this call today. Please submit your questions at any time using the Q&A box at the bottom of your screen. If you can avoid the chat, that would be fantastic. We will pick questions from the Q&A box. However, you can still use the chat if you have a hard time. We will address them during the dedicated Q&A segments, so feel free to drop them whenever you want while people are presenting. If you experience any technical issues, please message us directly in the Zoom chat and somebody from our team will assist you as soon as they can. For those that cannot stay for the full time or can only stay for a partial segment or what have you, these sessions are being recorded and they will be shared on YouTube and for those that are registered post-event at a later date. Now, none of this would be possible without the generous support of our partners and sharing our shared mission of education and resources to patients. So I want to extend our sincere gratitude to our sponsors, Medicine, Castle Biosciences, Immunocore, Merck, Bristol Myers Squibb, Regeneron, Insight, and of course, Pfizer. So a big thank you to them. Now, let's begin with a perspective that grounds everything we do, the patient voice. So it is my absolute honor to introduce Nigel Deacon. Nigel isn't just a patient. He was diagnosed in 2010, but he really is the cornerstone of this community. When told there was nothing to be done after his cancer metastasized, he channeled that experience into co-founding Ocumel Canada with our founder of Save Your Skin, Kathy Bernard. He wanted to ensure others would not face this journey alone. His story is one of resilience and tangible hope. So I want to have everyone please join me in giving a warm welcome to Nigel Deacon. Nigel, the floor is yours.
Thank you, Jasmine. Can you see and hear me?
Yes, you're good to go.
Good morning to everyone, and good afternoon if you're further east. I live in Victoria, BC, so my day is just starting. It's a great pleasure to be participating in our third annual symposium as we track with great interest the gradual change in ocular melanoma treatments. In June 2010, 15 long years ago now, I only had one thing on my mind. At the end of the month, I would move from the Lower Mainland to Victoria for an idyllic retirement, long planned and finally happening. I was moving into a beautiful new condo in an amazing new environmentally sustainable building. I had retired from the public school system 2 years earlier and was teaching part-time in the UBC Faculty of Education, and I would continue commuting for that. It's a beautiful ferry ride. I had just run my fastest marathon ever at the age of 61. I was also teaching yoga and was really enjoying that extension to my teaching career. The future looked blissful and bright. I was very happy. Life was just wonderful. My optometrist, who had taken care of my vision for all of her career, had emailed to say she was retiring. I decided it would be nice to say goodbye to her, thank her for helping me to see the world clearly through the years, and asked for a recommendation of a new optometrist. So I just stopped by unannounced. By chance, she had just had a cancellation. So she invited me in and proceeded to examine my eyes, even though I had not come for that. I had no symptoms. There was nothing about my vision that would cause me concern. A moment later, her voice changed, and she told me that I needed to go straight to downtown Vancouver, as she saw what she thought was a retinal tear. There, an hour later, the retinal surgeon, after an eye exam lasting less than a minute, said he was not the right person to help me and referred me to our BC ocular oncologist. She was out of town at an international conference, but saw me as soon as she got back, and I had brachytherapy shortly thereafter. That was all quick, efficient, effective, and frightening, but I was okay. My tumor was on the high end of medium, but away from the optic nerve, so I could still see. I was not offered a biopsy, which is now standard of care and very helpful for forward planning. Please note that my optometrist had never before seen a case of ocular melanoma during her 30-year career. We have more than 6,000 optometrists across Canada, and the vast majority of them will never come across the disease. That is what it means to get a rare cancer. I was also referred to BC Cancer back in 2010, as all ocular melanoma cases are referred to them. I asked the oncologist there if there would be follow-up scanning and was told there was no point. That was then. It is different now. I got busy with life and work and retirement and thought no more about it. In March 2012, just short of 2 years later, I had some inexplicable abdominal pain, which took me to emergency. There, a CT scan revealed several tumors in and around my liver. There was really no system to find my way through that period, so I just had to figure it out on my own. I remember it as being very chaotic. No one knew what to do, certainly not me. When I didn't like what an oncologist was telling me, I moved to another oncologist. I flew to the States several times to consult with emerging leading experts there. The era of immunotherapy was just dawning, and although Canada had not yet approved it, I was able to get compassionate access to it at the end of a clinical trial and had the first 4 infusions in the fall of 2012 in North Vancouver. Just imagine, diagnosis in March and first treatment in October, 7 months later. Imaging in January 2013 showed progression, and I was asked to register for hospice. Imaging in April 2013, though, just 3 months later, showed a mixed response. So I fought for and got 4 more infusions, unheard of at the time. Things continued to look up slowly for me. The cancer seemed to be losing its hold over me. I had 2 more rounds of infusions over the next couple of years with help from Savior Skin Foundation and a good deal of radiation, both broadbeam and stereotactic. And by 2017, 5 years after metastasis, I got to stability. And there I have stayed for the last 8 amazing years. Scanning sometimes goes wrong and things are seen that are not really there, so we work through that. On Monday, just 2 days ago, I learned that no new anomalies were seen in a scan I had just last Friday. So this week is a fantastic week for me, and it's wonderful to be here chatting with you. I hope you are doing okay too. As I look back at my ocular melanoma journey to this point, I feel sad that I have made so many very special friends in Canada and elsewhere who are no longer here. The disease has been relentless. I miss those friends a lot. I do notice, though, that more patients seem to be doing well for longer, and I hope that we continue to make progress in treatment access and effectiveness. I think, in retrospect, the hardest part for me has been keeping my anxiety under control. Before and after scanning, and in between, it arises like a specter. What is the disease doing? What news am I going to hear? I have learned to see anxiety arising in my body and mind, and I have gotten more effective in confronting it directly and refusing to let it eat me up. I know that anxiety has not helped me. I hope that you too can find ways to alleviate the anxiety you feel. Stay till the end of tomorrow's session for some insight into how you might get control over anxiety. Look around for methods that work for you. Lots of things help. You will find something that works for you. You are not alone. At the beginning of the journey, I knew no one else with this disease. There was no community. There was simply no way to find others. I found some online resources and groups in the States and grew closer to one in particular, where there was less drama and more information and support. I found my way into their organizational structure and attended and presented at their annual conferences. I kept my eye out for a way to build some kind of structure which Canadian OM patients might rely on in their time of need. It took time, and getting to know Kathy, founder of Save Your Skin Foundation and a very long-term survivor of cutaneous melanoma. The Save Your Skin Foundation had been founded in 2006, and as treatments for cutaneous melanoma improved dramatically, Kathy had become aware that outcomes for ocular melanoma patients were not matching cutaneous patients, and a supplementary support system was needed. We put our heads and our hearts together, and Ocumel Canada emerged in early 2019 as an initiative of the foundation, small and tentative at first, but over time, we found a path forward to where we are today. So where are we? We have a comprehensive website where you can find all of the reports and studies we have produced as we tried to make sense of the landscape in Canada for diagnosis and treatment. You will find lots of other helpful resources, including the kinds of questions you might want to ask as you face either a primary or a metastatic diagnosis. There's a website review underway, so if you have queries or suggestions, this is a good time for you to be in touch. If things are going really wrong for you, reach out to Ocumel Canada. Watch for the contact information over the next 2 days and keep it at hand. We have experimented with various ways of engaging with patients. You may have attended some fireside chats, especially those tailored towards OM patients. The search for more powerful ways to connect with patients and build community continues. We participate in awareness campaigns that engage with the general public and service providers. We run an annual fundraising campaign during Move for Melanoma so that we can help OM patients get to treatment. Many of you will have contributed to that, feeling a connection to fellow patients in need. Thank you for your generosity. It makes a big difference. We have a large private Facebook group. When I started it, I was imagining we might be able to find maybe 10 patients across the country. Currently, there are almost 250 members. There is a smaller group for patients with metastatic disease. The conversation gets heavier at that stage, and those patients feel more comfortable participating without causing extra anxiety for primary patients. Sherry Agresti from Newfoundland now oversees those groups and interacts with new members. You will see her often in the groups. We have just completed a groundbreaking study of the diagnostic journey of Canadian ocular melanoma patients. We have our final meeting on November 17 to discuss how that study will be published, and you will see it shortly after that. Our warm thanks go to the many patients, some of you perhaps here today, who participated. We have become very aware that we form two distinct groups. People with primary disease need ongoing eye care, whatever their treatment has been. This is not a disease that you can walk away from. There can be significant impacts on your work and your daily life. People who go on to develop metastases, and that is half of us, have different and acute needs for medical interventions in addition to ongoing eye care. This phase is the most difficult for sure. In closing, let me say that I have received excellent, compassionate care from doctors over the years. I have no difficulty in getting scans scheduled, and I hear the results really quickly. I'm very grateful for such good continuing care. I know this care varies enormously across the country. It will help if you yourself learn more about the disease, and you are here doing that today and tomorrow. We cannot change the rarity of the disease. We cannot change the known risk factors. We will always be a small group. Hopefully, we can change how well treatment works as advances are made. At the moment, the only approved OM treatment for metastasis is available in all our provinces, but it is HLA restricted. Most HLA-A*02:01 negative patients can access combination immunotherapy as the need arises. Where we fall behind is in controlling metastatic disease in the liver. As combination treatments evidently become more effective, let's speak up and ask doctors for access to treatments that reduce the burden of disease in the liver. Embolizations are performed often in our hospitals, but the system demands evidence of efficacy that is not yet clearly established for OM. Let's establish it. That is the challenge. At the moment, we do not have active clinical trials available in Canada, but that changes from time to time. For sure, ask your oncologist if there are trials recruiting when you need options. The trials open and close unexpectedly. The selection process is rigorous, and you have to be in the right place at the right time, at the right stage in your disease to get into a trial. I compare it to trying to jump onto a fast-moving carousel. On the bright side, there are now emerging trials elsewhere in the adjuvant and neoadjuvant setting, and this is an encouraging new development, and we hope they come to Canada soon. Perhaps we will get an update on that from Dr. Krema in the next session. We dream of a day when the disease becomes manageable. I wish you all the best on your journey, and please believe that it's possible to do well and be well. It has happened for me, and I hope from the bottom of my heart that it happens for you too. Thank you for listening. Thank you for being here. And now back to Jasmine.
Thank you so much, Nigel, for your powerful testimony and reminding us really why we do the work that we do here at Ocumel Canada and SYSF. I want to mention that thank you to Nigel for mentioning that we are going to be entering our 20th anniversary next year. And that means not only is SYSF celebrating Ocumel Canada celebrating, All Can Canada celebrating. We have a lot of incredible work that is based on the patient's voice. So as Nigel said, please feel free to share your opinions, your thoughts. I'll be sharing what we're doing tomorrow, and part of the session tomorrow is a discussion with all of you. We don't do anything without the patient's voice at the forefront of it. So thank you, Nigel, for that incredible presentation and that reminder as well. So now that we are going to be moving from the personal journey, after hearing that incredible story, into more of a clinical landscape. So we are very privileged to welcome Dr. Krema, who is the director of the Ocular Oncology program at Princess Margaret Center, a cancer center, excuse me. Dr. Krema's work in radiotherapy, surgical innovation, and molecular genomics helps shape the national standards of care in Canada. He will provide a comprehensive overview of the current clinical guidelines, best practices, and some information that has come up recently in the past year, such as the information you would have heard at ESMO or SMR. So I am going to stop sharing my screen and I will let Dr. Krema kick it off and give us all the updates. Thank you so much, Dr. Krema.
Thanks, Jasmine, for the introduction. It's my privilege to be here. And thanks, Mr. Deacon, for your inspiring talk. I'm learning from you and your endurance and your family. That's fantastic. So I'd like to share my screen here. If it is visible to everybody.
Yes.
Okay, so I'm addressing ocular melanoma from the ophthalmology as an ophthalmologist standpoint. As a bit of introduction, melanocytes are the cells that produce pigment that gives the color to the skin, the hair, and the eyes. Essentially, they are helping us to protect us against the damage from ultraviolet radiation. When they proliferate in a benign fashion, like a little bit out of pace from the surrounding cells, they start to accumulate and form what we call it a nevus, or what is known as a mole. But if it starts to proliferate aggressively and spread in the tissues and spread outside their original site, we call it a melanoma. The ocular melanocytes, when it comes to the eye, they exist in the eyelid skin, just like the skin elsewhere in the body. The conjunctiva, which is the surface of the eye, the membrane on the surface of the eye that covers the eyeball and then reflects to line the eye from the eyelid from inside. And the uveal tract. The uveal tract is, as you can see here from the demonstration, it's the middle layer between the outer surface of the eye, the white of the eye, the sclera, and the inner lining of the eye, which is the retina that receives light. So in between, there is this layer, we call it the uvea, which extends anteriorly to the front of the eye and becomes thickened just behind the iris to form what we call it the ciliary body, and then continue further to the front to form the iris, the color of which changes from one person to a person, depends on the amount of melanocytes there. So all of this is a continuous tract, and this can give rise to melanoma. So when we say primary ocular melanoma, there are actually two types. The one on the surface of the eye, which is the eyelid or the conjunctiva melanoma. They share things in common in terms of their progression and prognosis, and that's different from the uveal melanoma. The eyelid skin melanoma is quite rare. It represents less than 1% of the eyelid cancers. So there is not much to say about it, and it's not a common disease, quite rare. But more common is the conjunctiva melanoma. As I mentioned, it on that membrane that covers the eye, the melanocytes can give rise to a melanoma. The uveal melanoma, the uveal tract, as I said, it's the layer under the retina and in the ciliary body just behind the iris. And the iris itself all can give rise to melanoma from their melanocytes. So I'll go a bit about conjunctiva melanoma. So what do we know about it? It's quite rare. The incidence is 0.6 cases per million per year. So I would expect something in Canada about 25 cases per year. However, it represents 5% of all ophthalmic melanomas. It affects middle-aged and elderly individuals with fair skin. There is no sex predilection. It's non-hereditary. Although some genetic disease or chromosomal disease like xeroderma pigmentosum, which is a quiet disease, the patients do not have the capacity to fix the damage that happened from ultraviolet rays to their skin, they can develop multiple cancers, including skin melanoma. UV signature mutations were found in the conjunctival melanoma, proving that the UV exposure is a risk in conjunctival melanoma, similar as it is in eyelid melanoma. And that's not the case in uveal melanoma. It originates from what we call it primary acquired melanosis. It's basically a flat patch of pigmentation on the surface of the conjunctiva that it sits there for years, and all of a sudden we start to see a lump growing out of it, and that could be the start of a melanoma. It can start de novo without a previous abnormalities in the conjunctiva, or from a mole, which is unlikely, like you have a nevus setting in the eye, and over time it may change to a melanoma. So it has several presentations, has several phases that the practitioners need to be aware of it. The most common, as I mentioned, here on the left side, you have the area of PAM, or primary acquired melanosis, and the melanoma on top of it, or just a lump, brown with feeder vessels. Can be like a flat patch with some nodules within it. Can be very faint pigmentation in an early phase. It can be non-pigmented at all, like the melanocytes are proliferating as a cancer, but they are not producing pigment, so they can look like pinkish or not melanotic. Or sometimes after excision, it comes back, it comes along the scar area as multiple nodules. So these should raise the suspicion that you are dealing with a melanoma, and you should treat or refer accordingly to an ocular oncologist. The melanoma, the risk of melanoma of the conjunctiva has been divided clinically according to what we call staging, like how much of the tissues are involved. The most common one on the surface of the eye, these are by the TNM category, is the least aggressive. The ones in the corner or in the fornices, like when you pull the lid, it's behind the eyelid, these are the T2, which is more aggressive. T3 is when the tumor causes local invasion to the globe, to the eyelid, to the orbit. This makes it much more aggressive. Or T4, when the tumor spreads to the CNS, to the brain. This is like almost an end stage. So that classification helps us to modify the follow-ups. But also we identified the gene mutation that drive the course of the skin melanoma or the conjunctival melanoma over time. We have identified genes that when they mutate, they influence the course of the disease. And the more we discover of these genes, it gives us a chance to find drugs that can intervene with the action of these genes, what we call it targeted therapy. These are drugs that work on the expression of those mutated genes and help us to stop the disease from progressing. So we now know that there are a couple of drugs that are in use, vemurafenib and dabrafenib, that we use them if we find the mutation in BRAF gene in conjunctival melanoma. How do we treat conjunctival melanoma? Well, we have several options: surgery, radiation, cryotherapy, chemotherapy, targeted therapy that I just mentioned that works on mutated genes, or recently immunotherapy. So here are examples, like if you have a lesion like this on the surface of the eye, it can be easily excised. In addition, doing cryotherapy, which is kind of frostbiting the edges after excision, make sure that we do not leave living cells around. And usually this yields good results without any affection on the eye function or structure. Similarly, if you have a larger melanoma coming from the undersurface of the eyelid, it's possible to cut it at the base and treat it with cryotherapy, and that should be sufficient to control it. If we have a condition like this, recurrent, excised elsewhere, came back to us, and we find that it's stuck to the wall of the eye, if we attempt to just excise it and do the cryo, there are still cells embedded in the wall of the eye, the sclera. So they are like, they will come back. So what we can do is that we excise what we see. We do the cryotherapy as seen here, like you see ice at the edges. But then we can put radiation therapy, the radioactive flux, which is used to treat the uveal melanoma, we can put it to treat the seeds of the melanoma within the wall of the eye to prevent regrowth eventually. And we can get excellent results with no recurrence after that. If we have a diffuse melanoma, like it's not a mass, like just patches encroaching on the conjunctiva and the skin, here there is a role for topical chemotherapy drops that can kill the cells and minimize the burden of the disease. And then we can use radiation therapy for the residual disease, and that can help to control it. This patient had like 4 or 5 excisions before coming to us elsewhere. And when she came, she had this diffuse disease everywhere. So we put her on a course of chemotherapy drops, then followed by radiation, and she's been free for the past 5 years. If the disease of the conjunctiva or the eyelid extended behind the eye, then we can still excise, but then we use a different form of radiotherapy that can hit deeper into the tissues and can get rid of the deeper portion of the disease or the deeper cells of the disease, so we do not get recurrence. Now, in 2018, breakthrough happened in management, conjunctival and eyelid and skin melanoma, basically. The Nobel Prize was awarded to 2 scientists from the US and Japan for the discovery of immunotherapy. Immunotherapy idea, it employs the natural or laboratory generated molecules to release the capacity of the immune system to identify and attack tumor cells. Basically, you make the T lymphocytes, which are the cells that attack cancer, recognize that this is a cancer. This is not the normal cell of the individual, and allows to neutralize it and attack it as it attacks a bacteria or a virus or a foreign body. So that was really a breakthrough and helped us in some of the cases, the most advanced cases, like you cannot excise without sacrificing the eye or the part of the muscles, or it's too big to treat with radiation beyond the capacity of radiation to contain. So now we use immunotherapy for locally advanced or metastatic as a first line. And in some cases, we see like a complete response that disappears completely. Like in this case, after 5 months of systemic immunotherapy, cancer is completely gone. We did not need to use any radiation or surgery. Or as a neoadjuvant treatment, at least shrink the tumor enough that we can do a minimal surgery or use small dose of radiation. So how do we follow the patients with conjunctiva melanoma? The overall local recurrence ranges between 30 and 50%. It might be even less than that. These are like all the data from different centers, but it's still one of the cancers that we are worried that it may come back. The primary site of distant metastasis is usually the regional lymph nodes and the brain. We follow the patient usually by doing periodic head and neck MRIs or PET scans. Some centers, they go and take a biopsy from the local lymph nodes, what they call it sentinel lymph node biopsy, to check if there is micrometastasis. But this is the advantage of that over periodic head and neck, and MRI is still debatable. Who are the patients who are likely to develop metastasis? Those presented with greater tumor thickness. If they are non-bulbar, like not on the surface of the eye, but hiding behind the lid or in the fornices between the eyelid and the eye. If they have low tumor pigmentation, if they showed when we removed the tumor, it has histologic ulceration, or they showed local invasion to the wall of the eye. The mortality rate of metastatic in conjunctiva melanoma is 20 to 30%, hence the importance of early diagnosis and early management. I want to share here with you this situation. This patient came to us after she was seen by a community ophthalmologist for a mass under the eyelid, according to his description. He went and took a biopsy from it. The biopsy actually caused dissemination of the tumor on all the surface of the eye, as you can see, under the surface of the eyelid, on the surface of the eye, everywhere. So it's turned what was a localized disease that we can easily excise and do cryo, as I showed, into a diffuse disease that's becoming challenging to treat. So after battling with the disease, with the tumor for 8 months, with lots of chemotherapy, eye drops, and cryo, and we could manage to eliminate all the pigmentation on the surface. Having said that, few months later, the patient came with bleeding from the nose. So we found that there is a lump in the nose in the CT scan, and we referred her to the otolaryngology. They took a biopsy, and it was a melanoma. So this is what happened, is that when the biopsy was taken initially, it disseminated tumor cells, and it was taken with the tears into the nose where the tears drain, and the cells resided there and started to proliferate and form the melanoma, which ended with not a happy ending. So a paper was published years ago saying that the surgical technique of tumor management was found to be possibly related to tumor metastasis and death. Incisional biopsy, meaning taking just a piece of melanoma, should be avoided because it disseminates it, it makes easy problem turn into a difficult problem. So my message here to the practitioner is that if you encounter what you think is a conjunctival melanoma, please refer without a biopsy to the ocular oncologist to avoid complicating the problem by doing an incisional biopsy. Second part of my talk is about uveal melanoma. This also comes from the melanocyte, but it behaves completely differently from the skin and conjunctival one. Uveal melanoma is the most common primary intraocular cancer in adults. Why do I say primary? Because actually metastases from other cancers used to spread into the uveal tract, but usually we will not identify them until they produce symptoms. That was discovered in a study that metastasis might be the first cancer to involve within the eye to tissues, but primary would be uveal melanoma. The incidence here is 10 times that of the conjunctival melanoma, 6 cases per million per year. So expect something like 240 to 250 new cases in Canada per year. The most common area to be involved is the choroid, that layer that's between the sclera and the retina. Then less likely the ciliary body, 10% of the cases, and the iris is 5% of the cases. Again, it's a disease of the middle age and elderly. There's no sex predilection. The only identified risk is the light-colored iris. UV exposure is unclear. There are contradictory reports, so it's not really proven that UV exposure can precipitate uveal melanoma. It's not hereditary, but a disease was like a gene mutation has been discovered, which is a mutation in the BAP1 gene. It's on chromosome 3 that predisposes the carrier to uveal melanoma in addition to other cancers like mesothelioma of the lung, colon cancer, skin melanoma, renal cancer. And that's a hereditary disease, so it can run in families. We had a study and we found that it's actually less than 2% of our uveal melanoma patients carry this gene. It's important to check for it if it presented in a patient at a young age or he has a history of these cancers linked to this gene, because the patient needs to be under surveillance for the possibility of developing other cancers associated with this gene, and his family members need to be examined for this gene mutation. As Nigel mentioned, the metastatic rate of uveal melanoma in general is 40 to 50% of the patients, and the primary metastatic location is the liver in over 90% of the cases. How do we diagnose it? As ophthalmologists, we depend on the clinical exam. Because we can look at it in the face, we do not need to take a biopsy to tell us it's a melanoma. So the features that we can see by examining the eye can tell us it's a melanoma. So fundus photography, it looks like a mass raising the conjunctiva, as we can see in the fundus photograph, causing some retinal detachment around it by the rising tumor. It appears in the ultrasound as a lump with what we call it acoustic hollowness. Looks like a bit empty inside. It has its own network of feeder vessels, different from the feeder vessels of the retina on top. And tomography, optical coherence tomography, which is helpful for shallow melanomas, It can show us a specific appearance with fluid of the retina underneath. But in case if the media is opacified because the patient has cataract or hemorrhage and we cannot take pictures, and MRI can be helpful, although it's not routinely used. It gives a characteristic signal that can differentiate melanoma from other intraocular cancers. How do we treat melanoma when it's still inside the eye? So we have several options. Mainly, it's radiation therapy. There are two main techniques of delivering radiation to the eye. I'll come to these in details. There is a form of laser, we call it thermotherapy. There is a chance for surgical resection in a few cases, especially if the tumor is at the front of the eye. We can create like kind of a trap door in the wall of the eye and go excise the tumor from inside and cover it again. Although these techniques are not commonly used now because there are always cells scattered even in that trap door. So we don't do resection alone unless we're gonna apply radiation after that, or inoculation in advanced cases. Now, under trial now, there are two exciting new treatments coming. One is ocular injection of a virus-like drug that goes and sticks specifically to the melanoma cells. And then this drug is activated by laser. This is a treatment that is suitable for shallow, small melanomas in the back of the eye, that the laser will cause damage, selective damage to the tumor cells without causing damage to the surrounding structures. So if you are near to the macula, which is the most sensitive part of the eye, and you have a small shallow melanoma there, this might be give a better option than radiation, which will cause damage to the tumor and some damage to the macula and subsequently diminution of vision. And there is a neoadjuvant systemic targeted drug that aims to shrink melanoma before the definitive treatment of radiation. I'm going to come to more details about that eventually. So the first line of treatment, radiation, we have two methods of delivering radiation. What we call it brachytherapy. By brachytherapy, the radioactive source is put adjacent to the target volume. In this case, we put the radiation source on the wall of the eye directly. As you can see, it comes in the form of an applicator, round applicator like a disc, with these holes at the edge of it through which we can pass suture and fix it to the wall of the eye under the base of the tumor. Just as if you hang a plug on the wall, you hang this radioactive plugs on the wall of the eye on the sclera from outside, and the radiation can penetrate through and destroy tumor cells. The good thing about this treatment is that the radiation is almost confined to the area under the base of the tumor without causing much destruction to the tissues of the eye outside the radioactive plug area. And there are different kinds of plugs used. Each one has advantage and disadvantage. In our center, we have both iodine-125 and ruthenium-106. Iodine-125 is more common in North America and ruthenium more in Europe and the Middle East, but we have the advantage of using either. How do we adjust the dose of radiation? There is a sophisticated dosimetry software that we provide the radiation physicist with information about the size of the tumor and the location. And then they put seeds within this radioactive block that's enough to damage tumor cells without causing destruction to the surrounding structures. Usually we give our treatment over 1 week, between 5 to 7 days, so that dose accumulates gradually over this time. And by the end of the 5 or 7 days, all the tumor cells should be dead. Though the tumor will look the same, hasn't changed over the 7 days, but all the cells already destruction happened to their DNA, and the cells cannot proliferate further. And the tumor starts to scar and shrink in the following months to weeks. And that's the response to treatment. We can treat tumors up to 18 millimeter in base with the radioactive plugs up to 12 millimeter in thickness. And the treatment is successful in over 95% of the cases and killing the tumor cells. And our indications, as I say, of a favorable response is tumor reduction in height. We start to see scarring and shrinking of the tumor. We see the tumors becoming surrounded with the radiation halo, means that we did not miss on any part of the tumor. If there was fluid around the tumor at the base, starts to resolve. And these changes takes time, as I say, 3 to 6 months later before we detect them. But the tumor, as I say, dead at the end of the week of application of radiation. The second form of delivering radiation to the eye is teletherapy. Teletherapy is we use external radiation energy to hit at the eye from a distance. The indications for this is for tumors encroaching on the optic nerve. The optic nerve acts like a kind of a physical hindrance. We cannot put the plaque because the nerve is prevents the plaque from being pushed further to cover the entire tumor. So if the tumor is encroaching on the nerve, we cannot go from behind and put a plaque. So we shoot at the tumor from the front. And in cases if melanoma started to grow back in the 5% non-success with brachytherapy, we can use external beam to treat the recurrent tumor without the need to remove the eye, as a way to control the recurrence without the need to sacrifice the eye. The problem with external beam is it's not as localized as it is in the plaque radiotherapy. So we don't need to use it in the beginning because it causes more destruction to the tumor and the surrounding tissue than what we see with plaque radiotherapy. So it's a good treatment for recurrence to prevent inoculation, but we try to avoid it as possible when we treat. The advantage that happened in delivering radiation is that we move to what we call stereotactic application, is that instead of putting the whole energy in one beam that will destroy everything on its way, we split it into multiple beams and they go into a focus on the tumor. This is called stereotactic application. And also we divide the total dose that will accumulate in the tumor over multiple sessions, usually 5 days. That's all to reduce the toxicity or the intensity of the dose on the surrounding, the tumor surrounding tissues. So the types of teletherapy, the machines that deliver this radiation from a distance, we have proton beam, which is commonly used in Europe. We have the photon beam. It's a mega voltage photon, high energy photons that delivered, and there are two different delivery machines that give that, and gamma knife. So quickly, proton beam, which as I say is the most commonly used in Europe, has an advantage is that there is an inherent property to using protons or particles when we use them, is that the dose accumulates at the target volume without causing too much destruction to the surrounding tissue. So that's why it's a safer treatment for most intraocular, orbital, and adnexal tumor, that the dose accumulates in the target volume, the cancer, without destroying the tissues around. The disadvantage is that we need to do a surgery before we apply the radiation to localize where are the edges of the tumor for the machine to shoot in between. So it takes a surgery first. The other machine is the mega voltage photon. This is the one that we have here at Princess Margaret, and it's the most common. It's available everywhere. This is the standard of care for most of the cancers. It uses high energy photon, but the beam used is not small enough for the small eye cancers. Like the beam can be the beam used is about 10 millimeter in cut section, which is a little bit larger than is needed. So it hits the tumor and hits an area of the retina nearby, which causes some damage. This is, as I said, the most available type of teletherapy available in almost all cancer hospitals. And it's not designed for a small tumor volume. There are two delivery methods. One is, we call it the VMAT, where the machine rotates around the eye, shooting at the same tumor from different angles. So all of them come into a focus. This is the one that we have here. And there is one available in Quebec. which is the machine is held on a robotic arm and delivers the radiation in a stop and shoot mode. All of them, again, the same thing, the same energy, the mega voltage photon come into a focus at the tumor. Last is gamma knife that's been used for a long time to treat brain tumors or orbital tumors. The problem is the gamma knife is to deliver energy in one shot, not on 5 or 10 days as with proton beam or mega voltage photon, but it needs complete immobilization for a long time, which is difficult to achieve in the eye. The eye is a moving organ, even if you try to put anesthesia around the eye and freeze the eye so it doesn't move. It's very difficult to maintain stability in mobilization for a long time, 30 minutes continuous, to give one dose of radiation. So that's why it's not a common type of treatment for eye tumors. When we compare brachytherapy versus teletherapy, well, brachytherapy, as I mentioned, the radiation dose is localized to the area where the tumor is. But any form of radiation is associated with some complications. The rate of complications varies, depends on the amount of radiation used and the size of the tumor and where the tumor is located. It's common to get what we call it radiation retinopathies, damage to the blood vessels around the treated area, which can cause a reduction in vision. Damage to the optic nerve, which is less likely to happen, but it may happen if we treat near the optic nerve. Some patients develop cataract, some patients develop glaucoma. The likelihood of that, we did several studies and we find, yes, both if we use teletherapy or brachytherapy, stereotactic or plugs, tumor control rate is comparable, but when it comes to toxicity, the effect, teletherapy is higher than brachytherapy. As I mentioned, we try not to use it as a first line. We leave it for recurrent cases or cases encroaching on the optic nerve that we cannot treat with brachytherapy. The third line of treatment is transpupillary thermotherapy. It's a light treatment. It's a laser that heats up the tissues. It induces tumor cell death. We use it at the edge of the tumor that's next to the nerve. If we have a shallow tumor that the laser energy can penetrate through up to a thickness of 2 millimeters, and or if the tumor was controlled by brachytherapy, but there is a small, what we call edge growth, like because of geographical miss at the edge near the nerve, we can apply laser without re-irradiating. So we try to keep vision. Resection, if we have a patient like in this situation, we have a one-eyed patient, he lost his other eye and he has a large tumor. If we attempt to put radiation on this tumor, yes, we can kill the tumor, but we cannot damage the eye because of the significant dose we're using. So what we do is that we can actually remove most of the tumor surgically, and whatever left, we can treat it with just a small dose of radiation. So we kill any tumor cells that could be still in the bed and keep the eye and the vision. And that's what happened in this patient. He still maintains a vision of 20/40, excellent vision after 3 years in his seeing eye. Inoculation is the last resort if we have it, or if it's a large tumor that we cannot contain with radiation. And it's the technology of prosthetics have improved completely. That's becoming hard sometimes to identify which eye has been removed. We put a ball during the surgery to replace the eye, remove the eye volume. And the prosthesis sits on top of the ball implant that we put. 5 weeks later, the implant is moved by the muscles of the eye with the other eye, and the prosthesis is fashioned by ocularists who make it to look exactly same color, same size as the iris of the other eye, and it gives excellent cosmetic outcome. So I want to share with you this interesting story here. This lady came, she used to have routine liver scan for a disease called hemochromatosis. They check her liver every once in a while, and in one of her visits, they found lumps. So they went and took a biopsy and it came back melanoma. She was not aware of anything in her eye. Excuse me. So they told her that it could be coming from the eye, and we will refer you to the eye people. I look, and there is a huge ciliary body melanoma, as you can see. It's not affecting her central vision, so she did not have symptoms. So the treatment here was inoculation, but what would it serve if I inoculate an eye with a tumor larger than 20 millimeter base if the tumor already has a spread to the liver? And we cannot contain it with radiation therapy for something of that size. So I said to the patient, well, you're now on a drug that works on your liver metastasis from this melanoma. And since you're not in pain, you have your vision, and inoculation is not going to add to your survival. Carry on with your drug, and I will see you again in 4 months. If the tumor is growing rapidly and causing pain or troubles in the eye, we can remove the eye. That was in December 2021. In April 2022, 3-4 months later, she came and the tumor went like 50% down of its size. Never seen anything like that before. So that drug was the darovasertib. It was not having this name by that time. It was a trial drug with a number. And we find that it can actually cross the blood-ocular barrier and cause the primary melanoma in the eye to shrink. So that initiated a worldwide study, which is running now, and we are part of it, is that even without metastasis in the liver, and we have a large melanoma and we want to avoid inoculation, we give the drug to shrink the tumor, so we can bring it down to the possible treatment with radiation treatment. Or if it's a large tumor and we can treat with radiation, we shrink it even further, so we use less radiation and we can keep more of vision. So this study is going on now, and the results of it will be known soon in the coming few months. Last thing I want to talk about in uveal melanoma is estimation of metastatic risk. As we mentioned, 40 to 50% of the cases develop metastasis, and actually they come with metastasis in their liver when they come to the eye clinic for the first time. Just there is no way to test and tell, oh, there is something there in the liver or not, because MRI is not that sensitive to pick disease at a cellular level. It takes time, like a year or two, for the cells to form a small lump that can be detected by MRI. So in the past, we identified clinical factors that when we look at melanoma, we say, oh, this is possibly is going to spread. Patients with older age than 60, 65, if they have large base or thickness, if they have what we call a diffuse profile, like this situation, if you have a very large base and a small thickness, those that come primarily from the ciliary body, that thickening behind the iris, or if they present with extraocular extension, the tumor started to spread on the surface of the sclera. And besides other factors, like if it's a brown melanoma or this bleeding. So these are like general risk factors, clinical risk factors. Then came the TNM classification, which is a classification known to all kinds of cancer that classify the risk based on the dimensions of the tumor and the location of the tumor. So that helped a lot. It classified melanomas into 7 survival categories. So at least we have something to counsel the patient when they come, oh, we have this base and have this thickness and it's involving the ciliary body or having extraocular extension. Well, the chances of survival at 10 years is this number. But the problem is that within the same category, we still encounter patients, the same size tumor behave differently. So we stayed in the dark, like we cannot tell at an individual level when the patient or family asks us, what are my chances? We cannot really answer scientifically. But then came this paper in the late 1960 from a group of investigators in Germany. They found that a change is happening at the chromosomal level of the cells of the cancer can predict the metastasis. If you lose chromosome 3 in the cells of the tumor, the chances of metastasis go to 50% in comparison to the patients who keep their chromosomes number 3. The chances at 5 years is to have metastasis is 0%. They have 100% survival. So that initiated the era of individualized prediction. As the time passes, we started to identify changes happening in other chromosome and at individual genes, at the RNA expressed from those mutated genes, and finally the expressed proteins. And this is only by looking at these changes at the cellular level. So now becoming a routine to do a biopsy before we apply our treatment, whatever it is, or even after inoculation, we take a small biopsy from the tumor cells. This can be achieved, usually achieved by a needle inserted into the tumor before we apply the radiation. We dislodge some cells and we send and look for these genetic changes to tell us about the possibility of spread. And then we modify our follow-ups and our systemic surveillance accordingly. As I mentioned, it's done a quick procedure, takes extra 30 seconds during the surgery. At the base of the tumor, we insert and take few cells and send it for analysis. And that hole we create in the wall of the eye is immediately covered by the radioactive plug or the radiation. So nothing can leak outside, it will be burned instantly. And then that classified the risk for metastasis based on these changes into 4 categories. Depends, the more you have of these changes, the more aggressive the tumor, the more likely for it to spread. And even better is that we came now with an algorithm that combines the clinical risk factors with the genetic risk factors, and we combine them together to have more individualized curve for each patient, according to which we tailor the follow-ups and surveillance in attempt to discover the metastasis at the earliest phase possible, so we can initiate the treatment as early as we can, so we can get better outcomes. So in conclusion, the recent modifications in the treatment algorithms of uveal melanoma have improved the rate of tumor control and reduced radiation toxicity. Now we use lesser dose of radiation than what we used in the past. We are more precise in identifying what's tumor and what's not tumor, so we focus our energy on the tumor only. Plaque radiotherapy is the preferred method to treat whenever we can use it to EBRT. And iodine, which is the standard, also more than ruthenium, because we can change the location of the seeds and energy of the seeds to shape, to be compatible with the shape of the tumor or the location of the tumor. But still, we use ruthenium in small ones. Prognostic tumor biopsy of uveal melanoma is currently a common practice in most ophthalmic oncology centers, and we offer it here routinely. And luckily, that's becoming covered by the government of Ontario as a test before, so patients do not need to pay anything for it. It allows us to stratify the metastatic risks based on this information that we get. Once we know this information, it will help us in modification of the post-treatment metastatic surveillance frequency. We can see some patients every 3 months and other patients with low risk once a year. Some patients we need to do MRI every time. Other patients we just need to check maybe with ultrasound once a year. Early detection of metastasis and early intervention drives the patient to clinical trials. So now when I see a patient carrying the high metastatic risk, although I do not have an evidence of metastasis, I refer to Dr. Butler for follow-ups, trying to detect metastasis with MRI as early as possible so he can be enrolled in one of the clinical trials or start the treatment right away. And it's also a useful information for the patient and family for life planning. They know what kind of risk they carry after we successfully treat the disease in the eye. So that's it, and thank you very much for including me.
Thank you so much, Dr. Krema. I will open it up if anyone has any questions. I'm not sure if any of our panelists might have any questions or if there's any questions from the audience as well. Again, you can put them in the Q&A box at the bottom, or you can use the chat box as well. So if anyone has any questions, I'll just keep...
I think I see in the chat like 3 questions.
Okay.
You say if they ask receive a copy of the recording, this is for you.
Yes, yes. So we will be sharing this recording. I know everyone wants to know that because, again, your presentation was incredible. Want to watch it over again with some notes. Yes, it will be shared afterwards to everyone that has registered, as well as on our YouTube and on our website. I see here a comment from Nigel as well. Thank you, Dr. Krema. That was a fantastic presentation. It very much was. Okay. And I see a question here as well. So, Dr. Krema, are patients still being enrolled in the phase 2 trial?
Yes, if you're referring to the darovasertib, yes, they are. I think Dr. Butler will speak more in details about this study tomorrow.
I believe so as well. We have Dr. Butler and Dr. Wepler. I see another question here. So, when will the information for metastatic uveal melanoma treatments be presented?
Tomorrow, Dr. Butler.
Perfect. And I see here another comment as well. I agree with Nigel. Great presentation, and thank you for your commitment to our ocular melanoma patients.
I just want to add a comment because Nigel started by saying that most of the optometrists, they haven't seen that. Like this, as I say, like rare disease, 6 per million per year. So some of people might pass their whole career as optometrists. I've never seen one. And as you see, the earlier we discover, the better the outcomes at all levels. We catch the disease before it starts to spread. We use lesser amount of radiation to preserve more vision. So I was thinking like Ocumel would be the best platform to create something educational for the optometrists, since they are the primary eye caregivers in Canada. We can help arrange something that can be educational, and when you should refer this case to ocular oncology, oh, this is something not to worry about. It can be followed locally. And also to update them about how do we treat these cases. I think this is the first line of management of melanoma, the early discovery before we get into the big troubles and drugs, and as you can see.
Amazing. And I see Nigel's comment here that we've been talking about this, and we absolutely have been. It's something that we're planning on rolling out for 2026 because, as you said, it's a big challenge, and it's something that we need to educate not only patients but people that are in the field as well about, so they're more knowledgeable of this rare cancer. So thank you for highlighting that as well, Dr. Krema. Okay. So I don't see any more questions, so I will let Dr. Krema go. Again, thank you so much for an incredible presentation and for sharing your knowledge with us. We really do appreciate it. Thank you.
Thanks very much. Thank you, everybody. It's been a pleasure.
Okay. So, like I said, Dr. Krema's presentation was exceptional, and I want to quickly recap kind of what we talked about today. So we did hear a very powerful patient perspective from Nigel, kind of grounding us in that lived experience, but also reminding us of all the incredible work that we are doing here at Ocumel Canada and at Save Your Skin. We're celebrating 20 years next year, and we couldn't have done it without every single one of you that is on this call as panelists and as participants. Again, we want to hear your voices. We want to hear your thoughts about all the work that we've been doing. So I'm really excited to go over the agenda for tomorrow with all of you. So our shift tomorrow is going to focus more on, well, today we focus on the what of treatments to the how of navigating life with this disease. So day 2, we have an incredible panel with Dr. Marcus Butler and Allison Wepler, and they're going to be talking about optimizing care for metastatic as well as some other news and new things that have come out the past year, especially from ESMO and SMR. And then we're going to follow that up with a supportive care panel discussion. So that is really going to talk about the team and the real world resources that happen when you do get diagnosed with this form of cancer. And then we're going to close all of that with a discussion on how we could take all the information we've learned in the past 2 days and in the past year, and of course, like I mentioned, your voices, and move that forward into 2026. And that open discussion will be with Nigel and Kathy Bernard, our founder and president at Save Your Skin. And again, we're going to close the entire thing with a calming mindfulness session with our very own Leanne Westy, who is going to ground us after hearing all of that information and seeing all those pictures, because I know sometimes it can be a little overwhelming and a reminder. So we want to make sure we close it out with calmness. I am so grateful for all of you that have joined us here today. And a reminder, our call tomorrow starts at 11 a.m. Eastern. If you are getting notifications from Zoom, all of that will be emailed to you an hour beforehand as a reminder, and should be in your calendars as we jump into another invaluable session with everyone that I just mentioned there. Big thank you to all our participants today. A big thank you to our panelists today as well. And I wish everyone a wonderful rest of your afternoon and the rest of your day. Thank you so much, everybody. Have a good one.